Okay, sir. You say, sir.
Welcome to the PK Das Institute of Medical Sciences. PK Das Institute of Master Classes series. It is a 35th master class, and I welcome all of you to this meeting. And today's topic is being discussed by Dr. Jacab, and he will be introduced by our faculty, Dr. Wilson. He is a colonel retired as a colonel, and now working as head of the Department of Obstetrics and Gynecology, PK Das Institute of Medical Sciences. I would like to extend my thanks to the chairman, PK Das Institute of Medical Sciences, Dr. Advocate Krishnadas, and the Director of Operations, Dr. R.C. Krishnamar, for allowing and giving the support for doing such a program. And now invite Dr. Wilson for the proceedings. Over to Dr. Wilson, please.
Thank you very much, sir, for giving me this opportunity once again. I, on behalf of PK Das Institute of Medical Sciences, welcome Dr. Brigadier M.J. Jacab. He is a Seva Medal, retired from the Indian Army as a nuclear medicine specialist. As we all know, that he is going to talk to us today as an overview of nuclear medicine. I will first introduce him with his long CV, a lot of things that he has done for the Indian Army. So he graduated from Government College, Kottayam from 1986. He joined the AMC in 1986, that is in the month of May. He served as regimental medical officer for the initial 3 years, which is compulsory for all of us. I have also done that. And then he specialized in general medicine from Bombay University, from probably our Naval Hospital, Ashwini. And thereafter, he served in many of the hospitals as a medical physician. It so happened that he applied for his course in nuclear medicine, and he did his diploma from Army Hospital, Delhi in the year 2001. And thereafter, he has been serving in all of our command hospitals and the most premier hospital called Army Hospital, New Delhi, which is a research center too. And he in fact retired from Army Hospital, New Delhi in the year 2018. Thereafter, after retiring and giving up his uniform, he became professor and head of the department of MVG Medical College, Hosakote in Bangalore. And there is where he is now continuing to give his profession and his knowledge to the patients in that particular hospital, MVJ Medical College. I now invite him to give his talk, Nuclear Medicine, an overview. As we all know, when we were medical students long back, 4 decades back, what we knew of nuclear medicine was radiology. We used to say Department of Radiology, and we knew that those days there was a big photograph printed out in front of the department with a photo of Wilhelm Röntgen, because he was the one who discovered X-rays accidentally. And we also knew that mainly the radiology department was meant for X-rays and diagnosis of diseases in humans. Thereafter, the progress in medicine, the radiology, has been so vast with the inclusion of, the fission, nuclear fission, and the aspects of nuclear fission being inducted into the nuclear medicine in a big way. And we know that there are various forms of energy that is coming out from this explosion of the nucleus generated by these atoms, and they break. That is why it's called fission, and they give out many types of rays which are useful both for diagnosis as well as therapeutic purposes in our medical field. We know there are alpha, there are gamma, and there are beta rays, and also the neutral proton rays, which are also useful for various radiological purposes. With this little introduction, I call upon now Brigadier Dr. M.J. Jacab to elaborate on this fantastic, vast subject of nuclear medicine. Thank you, sir. Here, now it's your place to start.
Good afternoon, sir. Wilson, sir. Colonel Wilson, sir. Thank you for the nice words. I thank Dr. Andrews and team for giving me opportunity to talk about a topic which is dear to me because I have worked as a physician and then in nuclear medicine. And I find many times the awareness in medical fraternity is not up to the mark, and a good specialty is not being used for the benefit of patients. I thank my college management, our chairman, Dr. M.J. Mohan, our CEO, Dr. Tharani Mohan, and our principal, Dr. Ravi Chandar, for permitting me to participate in the lecture series. Now, about nuclear medicine. This is a branch of medicine which utilizes radionuclides for diagnosis and treatment. A radioactive tracer is administered and it is tracked in the body to see the function of a tissue or organ. Like in places where we can't reach, outer space we send satellite. Inside the body, it's a micro universe where we need to talk to the cells. If you want to talk to the cells, you have to talk the cells in the language of the cells. That means cells talk to each other with sharing of molecules and atoms. So we send molecules which cells normally handle and see whether the cells or tissue is handling the molecules the way it normally should be, or there's a change. Because in disease, the handling of molecules is different. And when we send molecules which are sending signals to us, like gamma ray, we can track them in the body, like we get signals from satellites. These are satellites inside the body. And we can get to the function of the organs. Basically, nuclear medicine is a functional studies, and it is time consuming, not like an X-ray where you take a deep breath, short, and then out. It takes hours to get a nuclear medicine information in the body. So the instrument which is used to detect the gamma rays, gamma camera. Gamma ray is basically why nuclear medicine name came, because gamma ray, beta ray, like Wilson sir told, alpha ray, they come from the nucleus, and these are being used in the nuclear medicine field. Whereas in radiology, it is the emission of energy from the orbiting electrons, which is used for X-ray or CT. So it is nuclear emissions which are used in the nuclear medicine. Radiology, it is the stimulated electron release the energy, and those are passed to the body as seeing the attenuation in the body tissues. They create images and information. That is radiology. Little bit about radiation. We are all exposed to radiation, whether it is radon in breathing gas or surface crust, thorium, and all those. We are all living beings are all exposed to radiation. So, but when the radiation is beyond a limit, it is harmful. Like this, just a few investigations where radiation is involved. Chest X-ray PAV, millisieverts is 0.02, and it is equivalent to 3 days of natural radiation. If you take chest X-ray as a unit 1, a skull X-ray, it's equivalent to 3.5 X-rays and equal to 11 days of natural radiation. And like that, if IVU, if you take, it is equivalent to 125 chest X-rays and 14 months of natural radiation. CT head, 2.3 millisieverts, it is equivalent to 115 chest X-rays and 1 year full natural radiation. CT chest, it's equal to 3.6 years natural radiation, 400 chest X-rays. CT abdomen and pelvis, 500 chest X-ray. I'm telling equivalent radiation dose and 4.5 years natural radiation. And nuclear medicine studies also, the minimum radiation is from the renogram and thyroid scan, which is equivalent to 50 chest X-rays and 6 months of natural radiation. Bone scan take more radiation, 200 chest equivalent to 200 chest X-rays and 1.8 years natural radiation. PET CT has more radiation, it's equivalent to 250 chest X-rays, which is equivalent to 2.3 years. So why I am telling is, anybody in asking a patient to undergo radiological investigation or nuclear medicine investigation should be aware that there is a radiation involved, which should be justified by the benefit which a patient get out of the investigation. Don't ask for radiation involving investigations without thinking about benefit. Nuclear medicine investigations are contraindicated in pregnancy. Otherwise, they don't cause any allergy or contrast problem. We can do it in a patient, even hemodynamically unstable patient also can undergo a nuclear medicine investigation. This is the picture of a gamma camera just for internet. This is the patient bed which can be moved, detector 1, detector 2, which can be rotated to take images as per the requirement. This is the PET CT machine, patient bed which can be moved in. There is a PET sensor which senses the emission from the patient, and there's a CT gantry which is emitting X-rays to take images. So there is a metabolic image and anatomical image, which are required and fused together, get metabolic and anatomic image together. That is PET-CT. The PET-MR is a new addition where there is an MRI gantry. This is very useful in neurological studies, in the metabolism of neurons and the anatomy of neurons. In any nuclear medicine department, there will be a radiopharmacy preparation area, measuring area. So because the radiation, while preparing, a lot of radiation is emitted, workers has to be careful. So every radioactive material is kept under lead shield, and the radiation department is always surveyed, because the radiation spillage, if it happens, we can't see radiation, we cannot smell radiation, we cannot listen to radiation, we only get irradiated. So we have to keep surveying the area to see that there's no contamination. Now, the clinical applications. Thyroid studies, it's very useful. I will explain one by one. Myocardial perfusion study, it's very useful. Renogram for renal function, it's very useful. Renal cortical imaging, reflex cystography, that is vesicular reflex, whole body bone scans, whole body iodine scans, parathyroid imaging, brain SPECT, hepatobiliary studies, GI bleed, gastroesophageal reflex, ventilation perfusion, and PET scan as such. These days, it's a hugely popular modality. Thyroid. Coming to thyroid, to relate the general structure and function of gland, whether a nodule is functional or not, then in a patient coming with thyrotoxicosis, thyrotoxicosis is the tissue reaction to higher levels of thyroid hormone, which can be due to Graves' disease, thyroiditis, fictitious thyrotoxicosis, toxic nodule. A thyroid scan can easily differentiate all this. Then see if a palpable nodule is functioning or not. If a non-functioning nodule, that means cold nodule. All of you know that cold nodule has got a chance of being malignant 15 to 25%, whereas a functioning nodule, it is less than 1%. So that information is important. Then to locate ectopic tissues, thyroid tissues like lingothyroid, determine whether a cervical or mediastinal mass is thyroid origin, evaluation of congenital hypothyroidism. Technetium thyroid scan is easy, whereas iodine study is a 2-day study, and first day the patient should be empty stomach for administration of iodine. Iodine 127 is the stable iodine. Iodine 123 emits gamma ray. Iodine 131 emits gamma ray and beta ray. Any beta ray emitting isotope is used for therapy because the radiation is much more. If we give 100 atoms of radioactive iodine or any iodine to a normal euthyroid person, in 2 to 4 hours, out of the 100, 6 to 16 will have been taken up by the thyroid, and in 24 hours, 16 to 45 would have been taken up by the thyroid. This is a normal thyroid uptake pattern, whereas in hyperthyroidism, it will be more, hypothyroidism, it will be less. This is a normal technetium thyroid scan. You can see the butterfly-shaped thyroid gland, both the lobes with the uniform tracer uptake. And you can see the parotid glands also, salivary glands also, because this trapping is by the sodium iodide symporter. Parotid glands also has got some sodium iodide symporter. But always see that the thyroid is more intense with the sodium iodide symporter, so it will be more compared to parotid glands. So we can calculate a thyroid parotid ratio and see that it is more than 2. Normally it is between 2 and 3, whereas if it is more than 3.5, it is hyperthyroidism, less than 2 hypothyroidism. So it's a normal structure of the thyroid gland. Same normal radioactive iodine uptake, iodine study. Iodine study, normal structure of thyroid. The uptake also is calculated here. 2 hours it is 13%, 4 hours 16%, 24 hours 25%. It's a normal. So this difference in the 16 to 40 wide range of uptake in a normal population, because some population is iodine rich due to the fortification of iodine in food items, some population are not. So iodine sufficiency varies, but generally this is the normal pattern. This is a iodine study of a Graves' disease patient. Thyroid is enlarged, you can see, and there is intense uptake, which is out of the 100, 77.9% is in the thyroid within 2 hours, and at 24 hours, 89% is in the thyroid. So hyperfunctioning, diffusely hyperfunctioning thyroid gland. This is a hypothyroid. See, the uptake is low, 5.15% at 2 or 4.3. So this is the hypothyroid case. This is thyroiditis. Patient is presented with thyrotoxicosis, but thyroid is not the villain. Thyroid is a victim. There is some inflammation causing non-function. Thyroid cell follicles are not able to function. The hormones which were stored in the follicles are poured into circulation, causing thyrotoxicosis. But thyroid is not producing more hormones. This is thyroiditis. This is a hyperfunctioning right lobe of thyroid. This is the iodine study. This is a technetium study in the same patient. This hyperfunctioning nodule has suppressed the left lobe. So uptake is 24 hours 51% and 48 hours 52%. This is a hyperfunctioning right lobe which is suppressing the left lobe. This is an autonomously functioning toxic nodule which is suppressing the remaining thyroid. So this is AFTN, patient presenting with a nodule and thyrotoxicosis. This is multinodular goiter. You can see thyroid is enlarged with the nodules of different shapes and different uptake of tracer. This is a thyroid, technetium thyroid scan where you can see half of the lower half of the right lobe is not functioning. This is a cold nodule. Such cases should be subjected to, patient should be advised excision biopsy rule out malignancy. Here you can see thyroid, it's a hypofunctioning thyroid with an extension retrosternal goiter in a hypothyroid patient. Here, this is a patient who had undergone left hemithyroidectomy. Technetium scan shows little bit of tissue there, and right lobe is intact, and there is lingual thyroid also. This is a child who came under evaluation for hypothyroidism. We can see there is lingual thyroid, no thyroid in the normal location. Normally, lingual thyroid alone is not enough for supporting the body metabolism. Now coming to radioactive iodine therapy. Iodine therapy is done with iodine 131, which is beta emitting. It's a metabolic selective internal radiotherapy. It's targeted therapy. That means cells which take up the iodine, which is emitting beta ray, will get destroyed. So we use it for benign conditions like Graves' disease and malignant conditions like CA thyroid. CA thyroid, we aim to have complete necrosis of the tissue. Graves' disease, you want moderate atrophy. That means reduction in the function. But sometimes Graves' disease patient treated with the radioiodine can go into hypothyroidism. Generally, it spares the other tissues because it's targeted therapy and generally pain-free. So iodine treatment can be given for Graves' disease, diffuse hyperthyroidism, multinodular goiter, where the patient cannot undergo surgery. Radioiodine can be given, especially when one of the nodules become toxic. Solitary toxic AFTN. This is a condition where iodine is the ideal treatment, because you give iodine 5 millicurie or 10 millicurie, this hyperfunctioning nodule will take up the entire iodine and get destroyed. And the remaining thyroid, which was suppressed or sleeping because of this nodule, escape the onslaught of iodine. It will recover from the suppression and start functioning. So patient will not go into hypothyroidism also. So the best way of treatment in AFTN is a radioiodine. Then CA thyroid, postoperative ablation of residual tissue, treatment to secondaries and treatment of recurrence, which I will briefly cover. Then in CA thyroid, everybody knows it is a total thyroidectomy, followed by suppression of TSH by L-troxin. TSH is a stimulant for follicular cell multiplication. So after surgery, patient has to be in replacement of thyroid hormone. But in the CA thyroid, we give a little higher dose of L-troxin to keep the TSH less than 0.1. And in between, after surgery, there may be some residual tissue in the neck or some neck nodes which are present in a scan. We treat it by giving radioiodine appropriate dose. And it's a curable disease because of this targeted therapy. This is a patient who underwent thyroidectomy for CA thyroid. We always call near total thyroidectomy, but because it's very difficult to completely shave off the thyroid. There will be some tissue. So this tissue was treated with 30 millicurie of iodine and it has been completely eradicated. And the follow-up, this is a case of extensive lung metastasis. As long as there are no nodules, this also is a curable thing. You give 50 or 100 millicurie of iodine, it can cure this disease. Whereas this is a follicular shear thyroid which has gone into bone mets, left femur, right glenoid process. Once it has gone to bone, we can keep giving radioiodine to suppress it, but we can't cure it. The side effects is radioiodine therapy when it goes more than 800 millicurie cumulative dose. 5 out of 100,000 cases undergo bone marrow suppression. So that is a problem. So that should be explained. So we generally give 30 to 50 for local. So minimum required dose to do the job. That is, so for bone mets we may have to give 100 to 150 millicurie. For local and nodes we may give 50 to 100 millicurie so that the person's bone marrow doesn't get into suppression. And if the dose is more than 30 millicurie as per the ARV, the person has to be admitted. He has to be kept in a separate room with a separate toilet with a delay time because the person's excreta contains radioactive iodine. It cannot be connected to the common sewage. So there should be a delay tank in which the water is kept for 10 half-life, that is almost 3 months. So there should be 2 tanks. One is opened every 3 months apart time. So that some people working in the sewage should not get irradiated. This is an image of a parathyroid adenoma. Now, myocardial studies. I will be a little quick in going through because every topic has to be covered. I will be giving overview. Myocardial studies are physiological studies which are non-invasive, safe. Inject a tracer which is taken up by myocardicytes and see how it is. Once you inject, it will reach the cardiomyocytes depending on the perfusion in that area. So the tracer distribution will be a representation of the perfusion in the myocardium. So this can be done during stress as well as rest to see the stress and rest perfusion. It is a blood supply at cellular level because the tracer is taken up by the mitochondria. Physiological effects of a coronary stenosis. In an angiography, if a person has 2-3 stenosis of 40%, 60%, 70%, whether it is physiologically significant, do a stress myocardial perfusion study. And if it is normal, there's no need of intervening because natural bypass would have happened or they are compensating each other. Thallium was the earlier isotope. Now technetium-based agents are used because of the easy availability, less cost and less radiation. There is a physiology. Oxygen extraction by a cardiomyocyte is very efficient. It extracts almost 80% of the nutrients in the first pass. So when there is an exercise of stress, when there is increased requirement for the cardiomyocytes to contract more frequently, there has to be extra supply. Extra supply means the coronaries dilate up to 4 to 5 times to supply extra nutrition to the cardiomyocytes. A stenosed vessel cannot dilate. So the vessel supplied by stenosed vessel, the myocardium will be ischemic. So that is called stress-induced ischemia. And the injected tracer will distribute in proportion to the regional perfusion. Perfusion defect can be reversible or fixed. Reversible means induced rest everything is fine, but when the demand goes high because of the narrowing, it cannot increase the supply. Whereas it's a fixed perfusion defect means it is a scar, infarct area. No point in going for a salvage procedure. This I covered. Now technetium sestamib is the commonly used tracer. Depending on local perfusion and metabolic activity, we need to give 2 injections to see the rest steady and stress steady. This can be done on the same day or 2 days. If it is same day, both studies are done generally around 4 hours apart. That means generally all nuclear medicine studies, if a person is going, be ready to be there for 5-6 hours. So, but many centers now what they do a stress study, and if it is normal, forgo the rest study because if the stress perfusion is normal, there's no need of doing a rest study because it will be normal. Stress can be physical stress like treadmill in Bruce protocol, modified Bruce protocol, bicycle ergometer. And if a person cannot exercise due to arthritis or any other reason, pharmacological stress, dobutamine mimics exercise, whereas adenosine is a vasodilator. The optimum stress is achieving a target heart rate that is 220 minus age or at least 85% of that. That is if the person's age is 40, 180, 85% of 180, the heart rate if is achieved, it is supposed to be satisfactory. or else double, that is peak BP into peak heart rate. If it crosses 25,000, it is an adequate stress to the myocardium. Other endpoints, you cannot aim to achieve these targets if the person develops angina. That means there is ischemia, inject the tracer and image. If there is arrhythmia, inject the tracer and arrhythmia, image. ECG changes of ischemia, or fall in systolic BP more than 10 millimeters of mercury, or severe fatigue. Severe fatigue means LV dysfunction starts. So fall in BP means LV dysfunction. So at that point, inject the tracer. The tracer will go to the myocardium as per the proportion of the blood supply at that point, and since it is taken up by mitochondria, it will remain there. You can image after 10-15 minutes when the respiration settles down, and it will show the perfusion at the time of injection, or at the time when person achieved adequate exercise or developed symptoms or ECG changes or fall in blood pressure. So that will show the perfusion at that time. The patient need to be fasting for 6 to 8 hours for a myocardial perfusion study. This is to keep the splanchnic circulation dormant, to give preferential blood supply to skeletal muscles and cardiomyocytes. Better to stop beta blockers 12 to 24 hours in advance, because beta blockers will affect the heart rate response. Omit nitrates for the morning, that day morning, keep it with the patient. Pharmacologic is either dobutamine, which mimics physical exercise. It increases heart rate. So the target heart rate has to be achieved, or any symptoms or ECG changes. Adenosine is a vasodilator which is infused over a period of 6 minutes. When adenosine is infused, normal coronaries will dilate, whereas a stenoid coronary cannot dilate. So if you inject a tracer at 3 minutes over a period of 6 minute infusion of adenosine, the tracer will get distributed in the myocardium as per the blood supply. So normal vessels will have good perfusion, good tracer uptake. Stenosed vessel blood supply has not increased, the flow heterogeneity has increased, so there will be less tracer. So in diagnosis of IHD and CAD are not synonymous, I mentioned. Then risk stratification in people who are at family history of ischemic heart disease, or any other procedure has to be undertaken, all those things. Then physiological significance of coronary stenosis can be found out. Myocardial viability study by PET, I will explain subsequently. Acute coronary syndromes also, you can inject and see whether the pain is due to ischemia, but normally it's not possible in our settings. Then this is very important. Evaluate success of a revascularization procedure. Whether the revascularization procedure has perfused the area, that can be detected by a perfusion study, and whether the myocardium has come back, regained its contractility. Or symptoms after revascularization. Is it due to myocardial ischemia, or is a musculoskeletal origin? This I mentioned. Multiple ischemic stenosis. These are all confused areas. Anatomy is not physiology. So a physiology study is better to take the decision. Then peri-infarct ischemia and areas of ischemia other than the infarct area, and a low-level exercise and perfusion study before discharge to give confidence to patient. All those can be done if possible. Hibernating myocardium and stunned myocardium. Hibernating myocardium is a myocardium which becomes slowly ischemic. So myocardium prefers to metabolize fatty acid to get lot of energy, calories for its contraction. It needs lot of energy to contract continuously. But when the perfusion is slowly reduced, myocardium switches the metabolism to glucose because it is easy to metabolize. But once it switches to glucose, it's not enough to give the contraction, so it becomes akinetic. It survives. Hibernating myocardium is viable myocardium surviving on glucose metabolism, but it is akinetic. Whereas stunned myocardium is a akinetic myocardium which has become akinetic due to the recent ischemic insult, and reperfusion has been achieved either by stenting or whatever it is. Perfusion is there, but it is the contractility take a few weeks to regain. So this is a myocardium which will recover over a period of time. This is a myocardium which needs to be revascularized for regaining the contractility. Coming to some images. So these are the axial cuts of the left ventricle during stress, during rest. This is the anterior wall, inferior wall, septum, lateral wall. Anterior wall, inferior wall, septum, lateral wall. This is the membranous septum. As you go to the base, septal side is membranous septum. So you can, this is a vertical cut of the left ventricle, anterior wall, inferior wall, apex. During stress, from septum to lateral wall. During rest, from septum to lateral wall. This is the horizontal cuts of the left ventricle, septum, apex, lateral wall from above to below. During stress, during this, you can see the tracer has reached everywhere. That's why we can see it. If there is gamma emission from my area, we can see it. So this is perfusion is there. Tracer has reached normal stress myocardial perfusion study. Whereas here you can see the anterior wall, there is a filling defect. Tracer has not reached perfusion defect, which is present during stress and rest. That means this is a scar or hyponatic myocardium, which need to be addressed. Here you can see a perfusion defect during stress in the inferolateral area. Always you can see two cuts. One is the axial cuts, and here also in the inferolateral area there is a perfusion defect which is getting normal during rest. So this is called reversible perfusion defect or inducible ischemia. So this myocardium is viable, revascularize, it will become normal. Otherwise it may go into infarct. TMT, why not TMT? Why myocardial perfusion? See, TMT in almost 1/3 of cases, it throws up false positive and false negatives. So if you give a report based on the TMT alone, we may be giving lot of false report. Whereas if you combine with myocardial perfusion study, this is a positive TMT, normal perfusion. It gives more than 90% sensitivity and specificity, confidence in handling the case. See here, the person has exercised. TMT is normal, but he had chest pain and all. When they did the perfusion study, there is a large perfusion defect in the septum and apex, LAD territory, which is reversible. It will become normal during rest, stress. So TMT is not showing it. So TMT, it's better to complement TMT with myocardial perfusion study if you want to be more sure of what you are handling. Here you can see septal myocardial perfusion during stress, which is normal during rest. Again, perfusion defect in the basal septum, which is becoming normal during rest. All reversible perfusion. Here it is a perfusion defect which is persisting during stress as well as rest. So it's a scar. Distal inferior wall, distal RCA territory, there's a scar. This is a triple vessel disease. See, one is the dilated LV, perfusion defect in anterior wall, lateral wall, inferior wall. Septum is perfused, but during exercise, the perfusion area becomes less. So triple vessel disease with LV cavity dilatation, poor LV. This person had symptoms at low level of exercise and was taken up for CABG. This is a person who had undergone stenting in the anterior wall, that is LAD stenting. But after 3 months, he developed symptoms on exertion. He underwent this test. You can see there's a perfusion defect in the anterior wall during exercise, which becomes normal during rest. That means there is a partial occlusion of the stent occlusion. So post-procedure symptoms, good to have this study for evaluation. This is a case of asymmetric septal hypertrophy. You can see the septum is thicker than the lateral wall. Septum is thicker than the lateral wall. And during exercise, because of the thickness of the cardiac muscle, the coronaries are not able to supply the endocardium. So there is LV cavity dilatation. This is hypertrophic cardiomyopathy. You can see the LV ejection fraction, motion, and also wall motion. Here the ejection fraction is 79%. This always help in better analysis of the regional wall motion. Earlier we used to move the arm, but now the software in perfusion study itself give a tool which the function. We don't have to do MUGA separately. This is a dyskinetic distal anterior wall. It is ballooning out in case contracting. Dyskinesia. Same in axial cuts. Distal anterior wall is not it is dyskinetic. So this is about myocardial perfusion briefly. Now ventilation perfusion can just briefly. You give a radioactive xenon or a radioactive aerosol DTPA, make the person inhale it deeply. So entire lung will have radioactive gas, you image it. So when if the ventilation is normal, you will have a normal distribution. And in a case of pulmonary thromboembolism, there are areas which is not perfused. So inject particles which are a little larger than RBCs. So they will get settled in the capillaries. Whereas if there is a larger vessel which is occluded, there will be areas where it doesn't reach. So you will have a perfusion agent which can say which is the area which is not perfused. See the ventilation perfusion mismatch. This is a xenon inhalation time. It is reaching all areas. This is a washout time. So it is a normal ventilation. That means when lung is ventilated. See the perfusion, there are multiple perfusion defects in the right lung. So positive for pulmonary thromboembolism. Is another normal ventilation, perfusion, multiple defects. Pulmonary thromboembolism. But these days, CT pulmonary angiography is there. So this may not be, because this is again time consuming, that is the problem. And this ventilation study give a lot of radiation to the radiation worker, because when the person is breathing in and out, lot of gas escapes the mask. Coming to nephrourology, very useful modality for nephrourology to see the renal function. DTP is a inulin analog. So you attach the technetium to DTP and see the kidneys handling it. And DMSA or GHA, they get attached to the cortex. So you can see the cortical anatomy where there's a cortical scarring and all those things. Then renal transplant evaluation, reflex studies, cystourethropy. In renogram, patient should be well hydrated, and before the study, patient should empty the bladder, because it's a half-an-hour study, and we may give diuretic in between. So patient should not say, I cannot hold. So make sure that the person empties the bladder and is well hydrated before the study. Renal function, baseline and follow-up in diseases like hypertensive nephropathy or whatever it is, obstructive uropathies, transplant kidney evaluation. This is a normal renogram. You can see this is the graph which shows the perfusion. The aorta, it should reach the aorta. It should be injected as a bolus into a large vein. There should be no extravasation. Then the calculation will go. We are counting the activity in the syringe, injecting. Then we are calculating counting the activity remaining in the syringe and calculating how many atoms of microcuries have been injected into the vein. So there should be no extravasation. And once injected, the bolus should reach the aorta within 2-3 seconds. And the kidneys should concentrate and peak should reach within 5 minutes. Here it has come with around 2 to 3 minutes. It has come. And then the kidney should clear it within 10 minutes. It has done it here. So this is a normal, and we can see the kidneys also, serial images and the summation of the images, normal location, normal outline of the kidney with normal function. We can get the GFR 50.8 and 48.7, total 99.5. And split function also 51 and 49 for renal donor evaluation. Total GFR should not be less than 70, and the split function, both kidneys should not be less than 40% for a eligible renal donor. So the donor evaluation renogram is done as a routine. Perfusion normal, clearance normal. This is the thing. Cortical phase and exudation. All the three are normal. See, this is another study, chronic kidney disease, contracted kidneys, not taking up the tracer much. And then, so the tracer is circulating in the background because the kidneys aren't efficient. There's no peak. Total GFR is 17.7. So it is chronic kidney disease. This is another normal cortex. See, the GFR is normal, but see the peak. It is accumulating in the kidney because the pelvic ileal system is dilated. When we see the clearance is not happening by around 8-10 minutes, we give Lasix. When more volume reaches the pelvic ileal system, it clears if there is no obstruction. So this is a normal cortical function, normal perfusion, cortical function, and a non-obstructed, dilated pelvic ileal system of both kidneys. So there is no procedure needed. Only thing the person should hydrate frequently to avoid stone formation. This is an obstructed pattern. obstructed pattern. See, the left kidney cortex is thinned, so it is getting damaged. Here, this is a left kidney. GFR also has come down because of the back pressure. This is a ureteric stone which was removed and the function was regained. So this is a case where there is complete obstruction on left side. This is any of that same obstruction. Clearing it. So this is very obstructions. This is another interesting case. You can see there is a delay in the right. This is all renograms. We are taking the photo from the behind because the kidneys are behind. Except for transplant kidney, we take image from front. This is the right kidney. This is the left kidney. Right ureter, there is a leak. See, this is a post-appendicectomy case. After appendicectomy, the patient kept on complaining of right iliac fossa pain. Surgeon had a doubt, so he sent for a renogram. We found there is a urine leak. There was a nick in the right ureter which happened during the appendicectomy, and this. Was done and everything was cleared. This is a child with a small normal kidney on right side, ectopic malrotated poorly functioning kidney, which is shifted to right side. This is a transplant kidney. After transplant, there was some seepage. Neurosurgeon had a doubt whether it was urine leak. So he sent a case to us. We did a renogram study. From the kidney, tracer is coming to bladder only. If there was a leak, it should have come to the surface. So we told them no urine leak. So the wound healed slowly. This is a horseshoe kidney. So horseshoe kidney without any obstruction. Now renal cortical imaging. This is very important in pediatric age group. Children with UTI getting renal scarring. When there is a renal inflammation or scar, the treatment or follow-up has to be in a different way. Trauma, post-operative, and searching of ectopic kidneys. It's very useful. This is a renal cortical imaging. Left kidney normal, diffuse, normal tracer uptake, normal shape. Right kidney is almost completely destroyed, scarred kidney. This is a horseshoe kidney, normally functioning. This left kidney is normal, right kidney upper pole is scarred. This is a right kidney is normal, left kidney is mal-rotated in the pelvis. Both kidneys have got cortical scar, irregular outline. Both kidneys show scarring. This is incidentally detected single kidney which is normally functioning. One kidney is enough. Both kidneys together, if it is 100%, 35% of the total is enough to keep the creatinine normal. So with age or disease, there is a decline, but creatinine start increasing when the total GFR comes less than 35% of the total. Both kidneys have got scarring. This is a neonate with a single kidney and a mega ureter. Now, reflex studies, radiocystography, very useful to diagnose vesico-ureteric reflex. It gives much less radiation than micturating cystourethrogram. It can be direct, that means instill saline with a little radioactivity in the bladder and tell the person to evacuate or pass urine and do the imaging. There should be no black flow into the ureters normally. And indirect is when you are doing a DTP renogram, images may give the reflex. I will show both. This is a case where the bladder is filled with saline and radioactivity. The person is asked to pass urine. From the beginning, there is reflex to the left side. And finally, right side also, bilateral vesico-ureteric reflex. Right-sided vesico-ureteric reflex. This is during renogram itself, we can see the reflex into the right ureter. This is a child. Musculoskeletal system, basically it is used for bone mets. But the differentiation between osteomyelitis and cellulitis is very useful. When there is an ulcer or inflammation in the leg or anything, whether it is delayed healing is happening due to an underlying osteomyelitis, a bone scan will give a clear answer. Even before structural abnormality happens in X-ray, the bone metabolism changes if there's an inflammation. That can be picked up by bone scan. Then prosthetic joint loosening or pain in a prosthetic joint can be easily picked up by this study, whereas structural imaging may not be that useful. Fever of unknown origin, yes, it can be useful. In bone scan, no patient preparation is needed. It's a normal whole body bone scan, skull, mandible, sternum, vertebrae, all the limbs, normal. See here, it's a primary tumor of the lower end of right femur, showing intense uptake, but there are no bone mets. It's a tumor limited to lower end of right femur. Extensive mets. This type of metastasis happens in CA prostate, vertebra, ribs, pelvis. Same way, more extensive metastatic disease involving skeleton. And this type of mets, when there is bone pain, that can be treated by strontium, which emits beta rays and kill the nerve endings. It won't cure, but it is palliation, pain palliation. This is what is called super scan. Diffusely increased uptake in the entire skeleton. This is generally seen in small cell lung carcinoma. I told about implant or prosthesis evaluation when there is pain. A person who underwent total knee replacement of the right knee developed pain and little swelling. So we inject, and from injection time onwards we take the image. Normally bone scan we inject and take the bone image after 3 to 4 hours because it takes time for the bone to take it up. In 3-phase bone scan, when we suspect inflammation, we have 3 phases of imaging. That is, one is the initial injection phase, that means flow. We want to see the flow. Then the equilibrium soft tissue phase, that means what is happening in the surrounding soft tissue, and the bone phase, which is at 3 hours. So injection phase itself, there is hyperemia, indicating there is some inflammation. Soft tissue phase also, the surrounding soft tissue is showing more uptake compared to the normal left side. And in the 3-hour phase, around the tibial processes, there is intense uptake, meaning that it's all infected. These infected processes. This is stress fracture. These are very common in the military recruits who are not accustomed to the route marches and long runs. Stress fracture, they come with pain. X-ray may be normal, but a bone scan will be positive. If the person is not given some rest, that they will go into proper fracture. Give a few days rest, it will recover, because it's only stress fracture means the bone, there is some architectural stress which needs rest. This is a doctor who came with a few weeks of fever and backache. Investigations were normal, and since there was backache, I only suggested, why don't we do a bone scan? We are doing bone scan today. If you are free, we injected and took a scan. This sports pain. So this is 3-phase bone scan in a patient who had a femur fracture right with plating and nailing. It developed pain. You can see during the injection phase, the tracer flow is more on the right side, and in the tissue phase, 15 minutes, there is a lot of tracer around the soft tissue of the affected bone, and in the 3-hour bone phase, entire femur is having increased uptake, and the fracture site, there's no bone formation. So it's a infected implant which has caused osteomyelitis. When it was opened, it was all full of pus, so it had to be kept open for a few weeks till the time it heals. Then it was again fixed. This is a degenerative disease, osteoarthritis. This is common in all patients who undergo for pain and all. So that's about musculoskeletal system. Liver spleen scan, not very useful these days because ultrasound is very good. But just for completion sake, I am telling it may be useful for hemangiomas. Colloid bond liver spleen scan. If you give a colloid, it will be taken up by the reticular endothelial cells. So 85% will be taken up by the liver and 10% by spleen and 5% by bone marrow. And if the liver is not functioning properly, the colloid bypasses the liver and comes to spleen. This is called colloid shift. And this is a cirrhosis, liver cirrhosis, where the spleen uptake is more. See, irregular shaped liver. Academic interest. This person died 2 days after the imaging because hardly any liver function. There is no uptake by liver. Spleen is showing uptake. Now coming to hepatobiliary scan or HIDA scan, very useful, especially in neonatal jaundice and then biliary block, biliary leak after some procedure, choledochal cyst and all those things. Here there has to be patient has to be fasting, and in neonates we advise phenobarbital priming 2.5 milligram per kg BD for 5 to 7 days to increase the efficiency of the glucuronide transferase. So the jaundice may subside with that priming itself. So we do the scan after that. So this is a HIDA scan. At 20 minutes, you can see the internal biliary channels, intrahepatic biliary, right, left, gallbladder, common bile duct. This is a normal HIDA scan. The tracer is taken up by HIDA is a bilirubin analog. So liver cell will handle it as if it is handling bilirubin. Taken up by the liver and gallbladder is taking it up and then cleared. This is again after the meal, gallbladder should clear it, normal. This is a cholecystitis where you cannot see the gallbladder. In acute cholecystitis, gallbladder neck is edematous and blocked, so it will not go into gallbladder. This is biliary atresia. It's not coming out of the liver. I am hurrying up because I think time is at premium. Biliary atresia, biliary atresia, biliary leak. You can see it's coming out from the right side of the liver where there is some trauma. Biliary leak. This is a biliary leak into the pleural cavity, which is a rare thing. Person presenting with pleurisy. This is a gallbladder ejection fraction in people who come with chronic dyspepsia. This may be useful. You when you see the gallbladder, give a meal and see the emptying of the gallbladder. Here it is very inadequate. So gallbladder dysfunction, normal gallbladder function. G reflex and occult bleed. I will say briefly. You give a little juice or milk mixed with a little radioactivity and continuous imaging for a few 1 to 1.5 hours. In between, you can see tracer reflex into the esophagus. That is gastroesophagus. This children present with recurrent episodes of pneumonia. So it's very useful in them. Gastrointestinal bleed, occult bleed, which cannot be reached by colonoscopy or UG endoscopy, small bowel bleed, or intermittent bleed, which is missed in the colonoscopy. If you label the RBCs, RBCs will be intravascular in the heart, wherever there is a lot of blood like spleen and liver. It cannot be in the bowel. If there is a bleed, it will be seen in the bowel. You can see there is blood in the from the splenic flexure to the descending colon. This is a GI bleed. Brain spect in dementias and ictal spect in epilepsy, intractable epilepsy, it may be used. This is a normal brain perfusion spect. This is a case where there's a post-road traffic accident, lot of damage, no non-perfused frontal lobes, reduced perfusion the right side. Again, post RTA, frontal lobe on right side. This is Alzheimer's. As you know, I'm sorry. In Alzheimer's, the perfusion in the frontal lobes are generally preserved. Alzheimer's perfusion defect is parieto-temporal. You can see parieto-temporal perfusion defect. now coming to PET-CT, which is a huge topic in itself, but I will try to give an overview about PET-CT because in oncology,
sir.
without PET-CT treatment is not
Excuse
done.
me, sir, can I intervene?
Yes.
So can we have another session, sir? Because I think it is such an expansive subject. You have covered all the diagnostic aspects. We would also want to know the role of radioisotopes in therapeutic side. And also Dr. Muralidharan is there. We would like to know something from him also. So can we have another session from you, sir, next time?
For PET-CT, no problem, sir. Because
No,
PET-CT, I need at least
continuation of the
5
same
minutes.
subject.
Then only. If it is 5 minutes, I can finish off.
Okay, please continue, sir.
See, this is a CT image. The PET image is a metabolic image. CT image, structural image. When you fuse, you can see the structural abnormality and the metabolic abnormality. Same PET image, CT image, PET image, and the fused image. This is an adrenocortical CA, left side, which without a PET we might think it is a localized disease, but there is already metastasis different parts. So we know even if there is a debulking is done, yes, it will not cure, but debulking can be done. See, this is before therapy, after therapy, metabolic response. Ewing sarcoma, right femur, before therapy, after therapy. For therapy, same thing. This again, lung CA, before therapy, after therapy, there is some mass, but it's not metabolically active, so complete metabolic resolution. CA ovary presenting with increase in the tumor markers. So we PET-CT shows retroperitoneal nodes. This is, there are 2 lung nodules, metabolically active. One is this. So if you want to take a biopsy, take from the metabolically active. In carcinoma unknown, cervical lymph node, primary is in the lung. Cervical lymph node, primary is in the right tonsil. Brain tumors, imaging with different traces like F-DOPA. Glucose will not be efficient because glucose is the only source of energy. So entire neurons will take up. F-DOPA is a new tracer which can be used for tumor recurrence evaluation when a person. FUO, this entire aorta is taking up tracer. That aortitis is the cause of FUO. Gallium studies in prostate is coming in a big way. PSMA, gallium PSMA for diagnosis and lutetium PSMA for therapy. Neuroendocrine tumors generally are not amenable for chemotherapy, so octreotide analogs can be attached with gallium for diagnosis and lutetium for therapy. Myocardial viability studies. This is a normal. Here there is a absent uptake. This needs revascularization. This is scar. So to conclude, nuclear medicine is very useful in thyroid disease, myocardial perfusion, nephrourology, bone diseases, hepatobiliary scan, PET scan in a big way, and nuclear medicine therapy. Thank you very much for giving me 2 more minutes there. Thank you. I hurried it up through.
And from our deepest of our hearts, thank you for such a great presentation. The subject was fantastic, but I think many aspects of it, many of our students will find it difficult to understand. Even I found it a little bit difficult. So, but it was really exhilarating. And thank you for such a wonderful presentation, sir. I now invite Dr. Muralidharan to give some expert comments on the talk given by Dr. Jacab.
Thank you very much. It's a very interesting topic, and endocrinology uses the radionuclide facility, one of the most common specialty where radionuclide and nuclear medicine has got a role. Of course, as Dr. Jacab has mentioned, thyroid is probably the primary area, but we use it for diagnosis of aldosteronism or tumors of the parathyroid, like the BB scan, and we use it for pheochromocytoma. And now it is more commonly used for detecting radiation in patients with pituitary lesions. Once it is done, you want to do PET is one of the most sensitive scanning method or imaging method where we can see even
So could you
we
come
use a lot-
closer to your microphone?
Yeah, all. Am I better? Audible
Yes,
better?
sir. Better.
Better.
Yeah. So the most common approach is of course the thyroid imaging. But I am using maximally when there is a doubt between a Graves' disease and a thyroid. You get a toxic T3, T4, TSH. Want to know whether Graves' thyroid is very useful. What doubt?
There is some audio disturbance from your side.
It's a very useful specialty as somewhere else, I think it is not from my side.
Carry on, sir. Clear now.
So the nuclear medicine is one of the, we heavily depend as endocrinologists on the nuclear medicine facilities which are offered by the nuclear medicine department. Thank you.
Thank you so much, sir, for your valuable comments. I would now ask one question for Dr. Jacab, sir, from my side.
Sir.
Are you still practicing this nuclear medicine in this new hospital that you are working as professor and HOD, sir, or you're only doing physician's job?
Sir, in our MBJ Medical College, there's no nuclear medicine department, so I cannot. Otherwise,
It's not
it's a
there,
very
sir?
useful.
Is
Sir.
it
I
there,
am
sir?
not practicing
Not
after leaving army. I did not get a chance.
Okay. So why don't you then join something where you have nuclear medicine when you have done so much in nuclear medicine, sir?
See, it's what
know.
at
Maybe
the
you
time
want
of
to come
retirement,
closer to home.
life takes you in places where you are not planning. My retirement time, children were in Bangalore, so they told come here,
I know.
got a
Yes.
job here. That's why I want to come to Kerala, but somehow I'm stuck for the time being here.
Yes, sir. And I have a small question for you, sir. Any role of radioisotopes in treating prostatic cancer?
Sir, I hurried it through. Excellent question. Now with this prostate specific PSMA, na, sir, surface
Yes, sir.
membrane antigen, you can tag it with gallium to see where all it has spread.
Yes,
Then
sir.
the same PSMA tagged with the lutetium or yttrium can be used to treat it. It is targeted therapy, very effective.
Lutetium 177.
Sir. Lutetium 177 tagged PSMA is used for treating. Very
Yes, sir.
effective, targeted therapy.
Basically, they give out alpha rays, isn't it, sir? This
Sir,
type of,
alpha ray is, you are taking actinium. Now some centers in India is using actinium, which is alpha ray.
yes, sir.
Alpha
Because
ray-
initially we knew alpha rays had not got much of therapeutic properties because they couldn't penetrate. Basically, it was always
alpha
beta
ray,
rays.
there will be more bone marrow toxicity.
Yes, sir.
It gives lot more radiation because it's where it is and keep emitting radiation.
Yes, sir.
So as of now, approved is a lutetium PSMA therapy.
Okay. Thank you so much, sir, for the nice information. Because we are all males, we are very concerned about this particular problem, which comes out so insidiously, and then suddenly you find there is metastasis without knowing that you have a
That is
prostatic
true.
cancer
That's
many
true.
times.
Sir.
Sir, I will request any of the other participants, if they have any doubts or questions, you can send it in the message box, or you can ask sir directly. I think the subject has been so different that I think many of them are not so keen, it looks like, to ask questions, or they are all gone. Many are already left, it looks like.
Nuclear medicine is a
Anybody-
subject which is not
anybody
taught
from-
in the MBBS,
Yes, sir.
so nobody.
Yes, sir. That's what I was saying in the beginning, that when we went to the department, we only knew radiology as one X-ray and other is radiotherapy. And
Sir.
we knew nothing about this new thing
Ah.
that is called nuclear medicine now, with so much of advancement. Wonderful, sir.
Sir.
And I think with this, we'll come to the end of the session, sir. We will like to have another session from you sometime later on.
Hello?
I think Dr.
Hello?
Andrews will
Hello?
fix that. Who is it, please?
Hello, I'm Dr. Joseph.
Please.
Sir,
ask your question, sir.
yes, nice presentation. But just want to ask, any center in Kerala for this prostate nuclear medicine center?
Amrita is doing for somebody. I asked Dr. Shanmuga Sundaram in Amrita. They are doing gallium scan and lutetium therapy on a regular basis.
Therapeutically.
Therapy.
Okay.
Ah,
Thank you.
They have PETMR also. Amrita has got PETMR also. They are doing gallium PSMA scan for seeing where all it has spread, and then they are doing lutetium PSMA therapy for CA thyroid on a regular basis. Basically, on a regular basis means you have to have planned. Radioactive material cannot be stored; it will decay. So it has to be purchased for a person on a day when it is planned.
Okay. Basically, one more personal question. Where are you from, Kerala?
I am from Kottayam. I studied in Medical College, Kottayam.
Oh, so you may be knowing our principal.
Dr. Andrews.
Classmates.
Classmates in school, Andrews was much more intelligent, so he went into MBBS after a +2 or pre-degree that time. I got MBBS only after a BSc.
Sir, I have one comment. I also didn't get after pre-degree. I got after BSc. But these people cannot take BSc in later life. So we people are more matured. Other people are
Thank you,
plus
sir.
Very good way of thinking it. That's
Yes.
good.
Okay, so thank you, sir.
Thank you, Joe, sir, for your question and getting the right answer from Dr. Jacab.
Yes,
And
thank you.
with this, any participants have any doubts, anything to ask, sir? I think nothing is forthcoming. So with this, we come to the end of the session, sir. Thank you once again for a great presentation and a wonderful talk with you on a personal level too. And I think I will take your number from Dr. Andrews. So I'll keep in touch with you, sir. Thank you.
Thank you, sir. Nice hearing
Bye
from
bye.
you. Veterans should be in touch, sir. I would like to be in touch with you.
Thank you, sir.
Sir, thank you, sir. Good day.